Hello, parents and caregivers, and welcome. Tonight we are going to talk about ABA therapy, applied behavior analysis. Before we get started, just a couple introductions. I'm Erica Desper, founder of the Center for Confident Parenting and the Special Needs Collective, which is why we're here tonight. Mainly, I'm a mom on a mission. We had a very long journey to get our son diagnosed and supported in school. And I just want other parents to receive information they need to hear as early in their journey as possible. And that is why I've invited Stacey to chat with us tonight. As you may or may not know, ABA often gets a bad rap. So we're going to talk through why that's the case. Does it need to be the case? And just demystify some of the misinformation. Stacey is a board certified behavior analyst at Brave New Things, mental wellness counseling and coaching, and also a mom to two littles. And Stacey, I will kick it over to you to learn all the things.
Thank you so much. Thank you so much for having me. It's a pleasure. Hopefully I can share some helpful information and go over different parts of ABA. Just a little bit about me. So I am a mom as well. I'll kind of get into where my background is and kind of my clinical focus. But before we jump in, just to reiterate, this is a purely informational session. It's not designed to try to persuade anyone, change opinions, or discredit any experiences in ABA. And I'll get into that a little bit more as we get through the presentation. My goal is to share my experiences. So my experience as a clinician, my professional growth in the field. So I unfortunately can't speak to the actions and things of other clinicians that maybe parents have, worked with in the past, but I can definitely tell you my approach and my outlook and how that has also grown. And while, I always hope that people keep an open mind to the ABA field, it's not for everyone, and that's okay. There's absolutely nothing wrong with this not working for you or your child, and, selecting another therapy that is a better fit. So some of my clinical areas that I focus on, I love social groups. So I'm a big social programs person. I run two groups. One is our ABA play. So that's for kiddos that are ages 4 to 7. And that's really building on their individual goals, but in a social setting. So we're really working with kids on developing peer interaction. For some of our kiddos, it could be that we're working on things just as tolerating peers in their space, and, just trying to share. For other kiddos, it could be actually engaging in conversation and what that looks like and how to initiate friendships and what healthy friendships are. And then we also do a peers program. So it's practicing engagement and encouraging relationships socially, so peers. It's aimed for our preteens, and they are really focused on kind of getting into that, teenage life. So what are friendships? What are healthy spaces? What are different social things to be aware of? So we do address things like bullying, any type of victimization. We talk about consent, safety, awareness in the community. So really, again, they're approaching that independent stage. So how to keep them aware and safe, but build that independence and help them, grow socially. I also focus a lot on parent support. So I love working with parents just to see what providing resources I can help with, working on some strategies that they can utilize with their kids. I do a picky eaters program, and this is really designed for kiddos that fall in sometimes an area where insurance doesn't cover. So a lot of times insurance and programs like CHOP will focus on areas where there is either a medical concern when it comes to eating difficulties, whether it's swallowing, whether it is just intense food refusal. And then there are kind of kids that it's behavioral. There's nothing medically wrong. And they just are very picky and very stubborn. So I work with families in that area so we can enhance their food repertoire. We establish mealtime routines, and just consistency in working with the parents. And then finally, kind of on the other side of things, I also work with behavior management organizations. So doing things like leadership training, working on retention, working on staff productivity and how to increase that, but utilizing the principles of ABA.
Awesome.
So the big question, what is applied behavior analysis? So without getting all scientific-y, it's an evidence-based field. So basically that means that there is a lot of research and data to support the strategies and techniques that are utilized in ABA. We love data. So we like to use different data collection methods. And really that's to help us see what's working and what's not. So we can visualize this is where we started when we, tweaked this, added that, this was the result. So it helps us then say, this is not working at all, or this has created more problems, or yes, we're on the right track. Let's keep doing more of this. So we also in that, kind of realm use a lot of assessments because before we dive in, we want to see what's going on. We want to get as much information as we can to make sure that we're making a very personalized, centered approach. And we're not just kind of trying to put a blanket, plan together that will not work for the child or individual. And also a big part of ABA is reinforcement strategies, which I'll get into a little bit more. So reinforcement is huge. Basically the definition of reinforcement is whatever, that thing is that's reinforcing our behavior is going to increase that behavior happening more in the future. And if it's a good behavior, we love to see that and we want to see more of it. And then also just, working with the environment. So I'm a big natural environment teaching person. So, working with what we have, making environmental modifications if we have to, that is also, something that we'll talk about a little bit. So those are kind of the main concept areas, which we'll go into the treatment process. So there essentially are three components to our ABA treatment. So the first is assessment. If you are doing an assessment through a provider, we are actually provided 45 days through the Pennsylvania State of Regulations to do an assessment. This is where we should be talking to parents and caregivers and teachers, anybody that knows that child, understanding what behaviors we're seeing, understanding where their skills are, where their needs are. And then the big thing is why. So why is this behavior happening? We really focus on function because everything's happening for some reason. Even if it's not easy for us to see at first, it's deep in there somewhere. And then also sometimes it can be misleading why a behavior is happening. So for example, I always like to share, I used to work with a kiddo in a school setting. And every time there was a fire drill, so the fire alarm would go off, this kiddo would grab all the snacks that he could and he would book it. He was out. So face value, we're thinking, okay, he's taking advantage of everyone's getting up, there's movement, like I'm going to get some snacks and pocket them. When we dug deep, though, we found that this child had been adopted from an orphanage in Africa. And when the alarm went off at this orphanage, so thinking back to the fire alarm, the children there were taught to grab all the and run because it meant the orphanage was being raided. So here we have this deep-seated traumatic experience that's linked to the behavior. So we dig deep for those reasons because we don't want to put a Band-Aid over it. We want to address what's going on, what's the root of everything. That all helps us design the intervention. which is basically what is the programming we're going to do. When we do programming, ABA has a two-pronged approach, and sometimes it's only known for the one part, which is changing behavior. So yes, we do behavior modification, but because that behavior is serving a function, we need to replace it with something healthier. Simple example could be if someone wants attention in class and they're throwing things off their desk, we want that to stop, yes, because that's not appropriate. It's a disruption to the learning environment, but they still need to ask for things. So is it hand raising we're going to work on? Is it, saying something to the teacher? What is something that we can replace so they still are fulfilling that function or that need? Then the other side that gets missed a lot is skill development. So we want our kids to be as independent as possible. So that's looking at where their skill deficits are. Sometimes it's largely in communication, socialization, or it could just be daily living activities. We will break down those skills into as small steps as we need for that child to then become independent and successful. So we may take something as simple as toothbrushing and break it down into 20 steps, literally every step of that chain. And we will teach it step by step by step until the whole process they can do it independently. So again, that assessment helps us know where those skills are, where they should be developmentally, and what's holding them back. We always can't stress enough, focus on what the child can do. We don't focus on what they can't do. So we see where their strengths are and we build it and we enhance it. And then the last part is discharge planning. So a lot of times, ABA is not meant to be a forever service because it is considered intensive. It is meant to fade out. So it's meant to give, parents and caregivers the tools that they need to continue to maintain the progress, but also have tools in their tool belt if new behaviors arise in the future, or if there are other skills as that child gets older. Maybe they want to teach them how to, do a load of laundry or run the dishwasher, using those same kind of, breaking it down into steps and working things one by one. The discharge process is often difficult sometimes for families because it is talking about losing support. It's very important, though, that everyone's comfortable at the place we're at before discharge. So we do a lot of fade out where caregivers now will take the main role and we're there for support. We kind of are in the background, but we want to make sure that we're transferring skills appropriately, not that we're pulling out and caregivers are not comfortable or don't feel solid in the programming we have established, or the child is not showing maintenance. So that means their behaviors aren't regress to where they should be, or increase if it's a good behavior to what it should be, or it's kind of fluctuating. So we want to make sure that when we do discuss discharge, we're at a proper place for that. ABA is something we actually use in our daily life. So we think of it, and as I'll get into some of the misconceptions, as something that's done just with kids with autism. But it's actually woven into everything that we do. So we use what we call an ABC model, which is antecedent, what happens before the behavior, the actual behavior, and then the consequence. So in this realm, consequence isn't bad. It just means what happens after the behavior. So it just takes something as, your alarm clock goes off. If you hit the snooze button, the consequence to that might be you're going to run late for work. So that running late for work, if that bothers you, that's probably going to then lead the next time your alarm goes off, you're going to get up. If it doesn't really bother you, then okay, you might hit the snooze alarm again. So we use this in our realm of everyday. We feed off of, social approval. We feed off of things in our environment. For example, you start going to the gym and someone says, "Oh my God, you look great." You're going to keep going. That's going to give you that extra oomph to keep achieving your goals. So it is woven into, our daily lives, and it affects what behaviors we're going to do more likely in the future. So this is the big part of things, is really talking about why ABA gets a bad rap. And there are a lot of misconceptions about ABA. I wanted to make sure I don't say the word myth, because this very well may be happening. And I have had experience with other clinicians and providers where things like this did happen. So should they be happening? No. But they, absolutely, it depends on the provider and the clinician that you work with. So these are just things to, if you are looking at ABA and thinking about it, these are things to keep in mind if you are entertaining the idea of sitting down and talking with a provider or a clinician. If you kind of see these things happening in their approach, then, that should maybe be a red flag that this might not be the place or the clinician for you. So one I already mentioned is ABA is only for children with autism. So ABA is actually a broad field that, again, that is intertwined in a lot of different areas. We have actually, the FBI has a applied behavior analysis part of their unit. We use ABA with dog training. We use ABA when it comes to sports. We use ABA when it comes to addiction and rehabilitation. It's behavior modification, simply. So in any facet where we're trying to, change our behavior, make lasting effects, ABA principles are used. ABA limits choice and autonomy. So, I was doing some research and seeing some common things, and that was one I saw pop up a couple times. We should absolutely not be removing choice. This is where we should be, if anything, adding more choice. We want our children to learn their independence, to be their own person, even if we're starting with simple choices like, do you want to wear the red shirt or the blue shirt? Very much using those natural opportunities for them to have their say, to have control as well. Making sure that, the goals that we're doing are meaningful to them and helping them grow as a person and helping them, kind of achieve their own independence in whatever manner that can be. ABA uses punishment and bribery. So punishment was absolutely used way back. And when we think kind of just the mental health field, one local example is Pennhurst. When we look back at the, institution of Pennhurst, of how it was run and the abuse and the neglect, the field of mental and behavioral health has come so far, where punishment is not a thing. And I will actually say, in fact, in a lot of ABA practices, we don't even do timeout. So we really try to steer clear of anything that would be punishing. But there are components of ABA that can be. There is a component called overcorrection. So for example, if a child has a toileting accident, they may be, kind of told to go to the bathroom 5 different times to overcorrect. That's a technique that I personally don't use. It is something also just to be aware. And if your clinician brings that up, that's something to ask more information about. What does that look like? So there are definitely practices that would be considered, punishment in those realms. But definitely ABA is focusing primarily on reinforcement. Bribery is also something I hear a lot. So there's a big difference between bribery and reinforcement. So bribery tends to impact the person offering the bribe more than the person doing the action. So, and a good example is thinking, if a child says to another child at school, I'll give you $5 if you do my homework, the kid who's getting his homework done is definitely benefiting more in that situation. The other thing about bribes is sometimes they're given before the actual action of, so here's $5, now go do my homework, before you actually have that exchange. And bribery is not proven to influence that behavior again in the future. So reinforcement is where the action needs to come first. So first you do this, and then you get this. And reinforcement is all about what that person finds reinforcing. So, if you say to a kid, if you clean your room, you'll get a candy bar. If they hate candy bars, that is going to do absolutely nothing. If they love candy bars, great, then they will be motivated. So it's all about tailoring that reinforcement to what that child likes and what they will work for. So there is a difference there, and we always try to make sure that we're focusing on that reinforcement piece. A couple other areas that I found just, doing some research is at a table. So there is a style of ADA. It is called discrete trial training. And this is actually basically tabletop activities that are very repetitive. This is used mostly in a classroom type setting, and it's not used for extended period of time. This is used for when we're working on, maybe fine motor skills, or we're practicing different types of identification. So for example, we might be at a table with flashcards, and maybe we're trying to teach the child categories. So we might have a couple cards of, maybe a boat, a plane, and, a cucumber. And pick out the ones that are transportation. So picking out, we might teach different types of topography and things like that. So those are typically done at a table setting. Again, those should be very quick. They should not be there for extended periods of time. Usually we're only there for a couple minutes, and then they have a break or they're free to go. So mostly we really, really focus on natural environment. So play-based learning is huge. And a lot of times we use child-led, which is the child we follow. They lead the activity, and then we weave things in. So, they might pick a book. We're looking at the book. So we might use this opportunity to work on our WH questions. Who is that? What are they wearing? Where do you think this person's going? And then, just using the community itself. So access to the community is huge. We really want our kids to generalize their skills in the community. Sometimes we take that for granted. Something as simple as toilet training. They learn in their bathroom with their setup. Let's go to a Phillies game, and what is this automatic toilet? What is this automatic sink? It could be very disturbing for them to be thrown in that situation. So generalization into community settings is huge and something that we work on a lot. ABA is not collaborative with families. It should absolutely never be that way. We should be working with the families step by step in every part, whether it is the assessment, the actual treatment, and then, of course, the discharge planning. We don't know these kids nearly as well as their parents and their caregivers and their teachers, even siblings or grandparents that might be also involved in the treatment. So we always want to make sure we're on the same page. Sometimes, our views may be a little bit different about the type of goals. So, for example, we might work, maybe a parent really wants their child to tie their own shoes. They're tired of tying their own shoes. But we've noticed they don't really have fine motor skills. So we might work on grasping and different things like that first to get to there. So the approach is sometimes a little bit different, but your clinician should explain that to you. Like, we will get there. Let's do these prerequisite skills and teaching first. So that sometimes is the only place where there might be a little like, let's tailor it this way, and then we'll get to that big thing that you're looking for. There always should be answering questions. They always should be explaining, again, step by step of why. Why are we doing it this way? What does this look like? Why am I taking data on this? And make sure that your questions are answered. And then finally, one of the other common things I found is it doesn't recognize other therapeutic approaches. ABA has a history of being very siloed. And I can, tell you that has broken down tremendously in the last 10 years. We really incorporate other practices. So one big one that's coming up is ACT, which is acceptance and commitment therapy, which is very heavy more in your kind of cognitive behavioral realm. That has been merging greatly with ABA because that helps a lot with trauma. We've been doing and incorporating a lot of trauma-informed care. So utilizing different components that are, helping us address trauma. It could be, again, we work with kids that are in the foster care system that have witnessed domestic violence. So taking that trauma-informed care approach, and then also what we know about kids that have diagnoses such as autism, and merging it together. We also have things like art therapy, music therapy, again, play-based learning. So it really is woven, and we always are collaborating with OTs and speech and PTs and definitely other types of clinicians. So we want it to be a collaborative approach, and we want to be welcome and accepting of other practices, especially if they're evidence-based. So we always want to make sure that we are, open to learning about what's coming up and what's benefiting kids in other areas. Again, that might be more in the mental health realm or in different types of therapeutic approaches. So what to look for in a provider or clinician. So if you're thinking about, trying ABA, these are just some helpful things. One is making sure that the approach is individualized. I have worked at providers, and I will not say names, but I've worked at providers before where sometimes I'll look in a client's binder and it's the wrong name. And you can tell the protocol has just been printed from the last kid and put into a new kid's program binder without any changes. So making sure it's individualized, it's tailored to what your child needs. It's tailored to their strengths. It's tailored what's going to work for them. These goals need to be achievable. We never want to set them up for failure. We want to only set them up for success. Collaborative. So making sure, again, you're getting your questions answered. They're telling you and explaining every step of the process. They're engaging with you, appropriately. So, ABA clinicians usually aren't on call. So, but again, if you send an email or a phone call, that they should be getting back to you in a reasonable time and answering the questions that you have. You shouldn't be, only hearing from them here and there or seeing them here and there. They should be a regular, institution in your home or the school, and make sure they're always communicating with you. Teach how your child learns. So one of the big things is, we cannot expect kids to change the way they learn. We need to change the way that we teach to fit them. So again, not that cookie cutter. Like, let's see if your child isn't learning from just kind of saying steps. Let's add visuals in there, or let's do social stories, or let's do icons, or maybe we need to break this down to even simpler steps. What is the best way for your child to learn? Is it repetitive practice? Sometimes for some kids, that's the best way, practicing hanging up their coat as many times a day as possible. So making sure that we're, again, focusing on that what they can do and how they learn. Ability to dedicate time. So this is one thing I will say is that providers tend to push quantity of cases over quality of service. There are large wait lists for ABA. And unfortunately, that is kind of what a lot of providers look at, is how many cases we have. Clinicians that have an overwhelming case load aren't able to appropriately dedicate time, especially to kiddos that need it. Maybe there's multiple behaviors happening in multiple settings, and there's a lot of skills that we want to target. So that's important to sometimes keep in mind. And that's not always on the clinician. That's, again, sometimes the way and the mindset of providers. And also in that same vein a little bit is in the scope of the clinician. So in our ethics code for behavior analysts, it states very clearly that we are only to practice in our scope. So for example, if a clinician picks up a case where a child is having severe feeding difficulties and refusal, and they've never worked with a child like that or have any experience, that is their, ethical responsibility to tell you that. And that might mean, getting on another wait list or waiting for another clinician. But in the long run, it's beneficial because, you want someone that's experienced with the needs of your family and that can address them appropriately and has experience with that. For some clinicians, they might have supportive supervisors that have the experience they can work with, or other clinicians they can tap into. But that is something just to keep in mind. It is disheartening if you've been on on a wait list and you've waited and now you have someone and they can't help you. It is definitely disheartening, but in the long run and in the grand scheme of things, you want someone that can really say, I know what I'm doing and I know how to help your family, and like, let's work together. And then just kind of wrapping up, limitations of insurance and MA. So some things that, people have encountered as far as, hardships and difficulties with the field, so to speak, are more so depending on the limitations and the issues that we face on the confines of insurance. So some of those things just to keep in mind, authorizations. So to get an authorization, even if your insurance says, yes, ABA is covered, to get that actual authorization can be jumping through hoops. Sometimes it's a time-consuming process depending on who we're working with. Sometimes it can be, for some commercial insurances, you're trying to call and you get routed around, and then they only want to speak to, a supervisor, or then they want to schedule, a peer review. It can be a very long process just to say, okay, yes, we're going to pay for these services. Limited coverage. So many insurance plans have limitations on ABA therapy. So we are actually only able for MA especially to go by approved number of hours per month. So that means we might only be able to give you 20 hours. That's what they're approving. Even though you might love your therapist to be there 3 times a week, 3 hours a day, we are limited to sometimes the confines. In that same vein too, sometimes that one-to-one, like a behavioral health technician might not be approved. But a might. So sometimes it's different levels of service. So that is something to keep in mind, that we're often confined to what we're allotted and we can utilize within the insurance. Reimbursement rates, unfortunately, I think a lot of people that are in the mental and behavioral health field go through this, are pretty low. So, I know it's frustrating for parents to see turnover at, providers. They get comfortable with a therapist and you think everything's vibing and jiving, and then, they leave and you get a new one. Turnover is very high. There's compassion fatigue in this field. You are giving a lot, and you want to help everyone. But then, people have to live as well, unfortunately. So it is tough when you are confined to what insurances and MA will reimburse for those services. So definitely is a huge impact on quality of care. Documentation requirements is another big thing. We need to justify our services every time we ask for an authorization. And that is pretty extensive. We need to have very thorough treatment plans, submit thorough assessment, thorough crisis plans. The details have to be how we're using every single hour they're giving us, where we're going to be, what we're doing. It is definitely hard to, sometimes make sure we're always getting what we're asking. So we may go in asking for this many hours for this many types of service, and we may not always get it, no matter how much we submit to ask for it. Discharge challenges, again, insurance is wanting to see people come in, go out, and new people come back in. There's a lot of pressure. There is always pressure, especially for an intensive service like ABA, to discharge, to move to a lower level of care. Maybe that's, a type of outpatient service. There's always pressure to, when we're going to wrap up. And there isn't a timeline for ABA. There is no designated timeline in the regulations that you can only have it for, X amount of years or X amount of time. But insurances will definitely start to, if this is our second year that we're asking for services, we might start to get a lot of questions. And that kind of also goes into the last part of meeting the medical necessity. So sometimes it's hard to understand because we're saying ABA is for everybody, it's behavior modification. It doesn't just work with kids for autism, but we are also under the confines of ABA meeting the medical necessity, quotes, defined by those managing care organizations. So for a lot of, managing care organizations and insurances, it does mean severe deficits. Like there's got to be severe deficits in communication or intense behaviors. There needs to be aggression and elopement. For some kids, it's just we're just working through coping skills and we're just trying to get through the normal frustrations of life. That might not meet, again, that intensive level of service. So we do get a lot of pressure to meet their definition. Even in our minds, it's something ABA could absolutely work on. And ABA could absolutely work to build that child's, skills. So that's something that, again, is really a confine that we face. That is basically the overview that I had planned. I'm open to any questions at all. And then also I have my email on here. BNT also does 15-minute free consultation. So even if it's, I think I'm interested, I don't know, or I want to talk about my child specifically, email me. Happy to do a quick call. We can go over it. I can explain my approach a little bit more. But I'm always, open for questions and discussions. So.
Thank you. That was super informative. I do have some follow-up questions for you. But first, I feel like I need like a rinsing, cleansing breath after the limitations. And I'm looking at it as both like a professional who's not bound by taking insurance. I couldn't even take it if I wanted to. And as a parent who has encountered the challenges that you listed of no one takes what my son has, and when they do, the quality doesn't seem to be right to me. And that was a really good explanation of why. And as an admin of a parent Facebook group, I see and hear them saying very often, like, why are all these providers going private pay? It's making it so hard for families, but it really is about the insurance companies. It's making it really impossible. And like you said, in the mental health field, but really anywhere. I mean, my chiropractor stopped taking insurance because honestly, the copay that I would pay, like it just actually worked out better for everyone except the insurance company. Worked out well for her, worked out well for me. So we do want to acknowledge just how painful that is and how it puts families like in a position where they just don't have any great options. But just realize it really, when providers do that, I think it's so much less about the money and the reimbursement and so much more about wanting to have full control over how they interact with your child. And I can experience myself, like if I go to physical therapy and it says on the thing that I'm there for my, low back. Well, if they determine it's like coming from my neck, they can only work on my low back, right? Like we have to start all over and say neck. So you're like, you really are got to hone in and be just so limited. So sorry to parents, but hopefully that explanation, was really helpful. So one thing I didn't hear you mention that a parent might be wondering is, and I'm sure this varies, all these things probably vary from clinician to clinician and practice to practice, but like, is there an age group where this is proven to be more effective? Is it just open to anybody?
Sure. So open to anyone, child, adult. You hear definitely so more of it in child because, again, when we talk about MA and insurance, it's covered for children. So when a child that's in the mental or behavioral health field is at that age 21 and now is an adult, these resources in adult life decline tremendously. So unfortunately, because of just the resources and the way the state of Pennsylvania is designed, you see a lot less of ABA being covered by MA or being done when they reach adults. Children, definitely you see as young as they can. There is a lot of research proven that for like early intervention type services, so not just ABA, but any types of service that falls into early intervention, starting as young as they are sets them up for better success. One of the things, that we often see is when they're young, sometimes those little skill deficits don't seem huge. So, when they're a 3-year-old and they're really not interested in interacting with peers, or they kind of are doing their own thing, or they're lining up their toys, it doesn't seem, too different from what other 3-year-olds are doing. But when they're doing those behaviors and they're 8, and they're 9, then you start to see kind of the pull apart, from where they're supposed to be developmentally. So they always, encourage earlier better to have those foundational skills. I have worked in adult services for a few years, and it's such a need. It is such a need in there as well. So it absolutely can work any age group. You just hear, I think, definitely more about it being focused for children, and I think it's based off of those reasons.
And do you specifically have an age range that you work with or love to work with?
I have experience working with the littles. I have experience working with, when I've worked with adults, I've worked with adults in their 60s and their
Okay.
70s. So I am comfortable with any age range. But yeah, if for adults, I do have a real passion because it is so limited, the resources out there.
Wonderful. And I'm sure this varies a lot, but it sounds like you're seeing kids in office, in clinic. But is it true that sometimes ABA is, like you talked about, natural environment? Sometimes you're in the school setting, sometimes you're in the home setting or out in the community.
Yeah, yeah. So even when we do, sometimes that clinic setting label can be a little misguiding. It's really kind of like a preschool setting, when it really is. We do circle time, we do arts and crafts. So sometimes it is like, are they all sitting at tables and just doing, these cards and stuff? So even when we're doing like those clinic settings, it just kind of think of it as when you drop your kid off at, a preschool, or like they're just going to like an after school social group. That's how we always want them to be designed, even if they're on site. But we go anywhere. We'll go into the community. A lot of times we will meet families at restaurants to work on skills there, or we go to the zoo, we go places. So those parents have support. We do have parents that, especially if there's elopement concerns and safety, they're a little nervous, so having those extra hands and having that support out there, because we want those kids to have those experiences. So we go anywhere you want us to go.
Okay. And so I understand if it's insurance based, which is not what you do, you're limited to like a certain number of hours per month or however it works out. But let's say we're going private. Um, is there like a general, we'd see your child X times a week, or is it just super dependent on the child in the scenario and the goals?
Definitely dependent on the child. It depends on what we're looking to achieve. With BNT specifically, we are all telehealth. So for, kids I also work with in, like I said, in my other position, telehealth's not appropriate. They're not going to be able to sit there. They're not going to engage. They're not going to learn. So, that's also a big decider too, is if that type of approach is going to be beneficial, or if they are, like, it has to be hands-on and you actually have to be physically there.
Right. Okay. And then you mentioned that there are two prongs. One of them was the skill building, and you said that sometimes that gets like overlooked. Do you feel like that's part of the modernization of ABA, that's being brought back in, or do you feel like that's on a clinician by clinician? Like, look, there's old school medical doctors
Sure.
that don't even know the new information and can't be bothered to get up to speed. Like they really need to retire, right? So is it a similar thing here, or like how is it that prong gets either left behind or kind of comes front and center?
I think I think it's a little bit of both. I think it is just the field itself. I think automatically a lot of mindset goes to behavior. Not always thinking that a lot of times those behaviors are linked to skill, areas. So I think also that's where, like, forcing a child to change their behavior comes with that autonomy piece of changing them as a person. So, we really try to make sure sometimes the behaviors are directly linked to skill. If a child cannot form words to communicate their wants and needs, they're going to get frustrated. And then sometimes we give them, just being able to label things and say like banana, please, makes a huge, a change in when they're requesting for items. And, a lot of times we see a direct link to the behavior. So sometimes it just kind of gets, I think, a little bit overlooked, and it's always focused on we're changing behavior. But a huge part of that is the skill piece.
Yeah, I love that. And I'm a huge fan. Obviously, I help families whose kiddos struggle with sleep and potty training, not quite the data analytic way that you do.
Sure. Yeah.
It's more just parent coaching, but we are constantly learning and we're constantly trying to explain to parents that, behavior is communication. Big fan of Dr. Ross Green. Kids do well when they can, and when they can't or won't, depending on how we perceive that, it's either an unmet need
Yeah.
or a lagging skill. So to use an example like hitting at circle time, like you just mentioned, someone could look at that and say, like, this child needs to learn not to hit, but it's the digging deeper of maybe they're hitting because they don't have a word. They don't
Yeah.
have any words. And if we give them that, then the behavior will go
Sure.
away. So as someone who never did ABA and didn't even know about the whole hullabaloo until recently, I get it. I see how all of
Sure.
that happened, but I think there's just so much good to it. It's
Yeah.
really getting to the why behind it, and like you said, replacing that
Yes.
with a better behavior. I mean, look, even as adults, we often use maladaptive,
Right.
whatever, coping strategies
Sure.
or numbing strategies or whatever we're all doing, and we can just replace that with something that serves us
Yeah.
better and is a little more, socially acceptable. Um, this one might put you on the spot a little bit, and I think
Okay.
it's my last one, but I just thought of it. So one of the other sticky things I've heard is with like stimming with
Okay.
kids with autism,
Mhm.
that like, where do you can only speak for yourself. So where do you
Sure.
personally stand on modifying a stimming behavior?
Sure.
Um, just because maybe it's disrupting,
Yeah.
the kids in the class, or like I know parents get heated about that.
Yeah, absolutely. So research and the field has changed a lot in this area. And I am one of those that if it is not affecting their well-being, it's not affecting, their safety, we're not going to look at it. So there's a lot of, when the first thing I do personally is the question, does it need to be changed? So, I've, it was actually in an adult setting where, someone in a day program, a staff said they hum the same song over and over all day. You need to do something. Why? Why, so I'm much more, I look at stimming personally, again, I can only speak for myself, but it's the same thing as if, our leg is bouncing or we're biting our nails, or, we don't know, is it something they could even control? Is it very reflexive, or is it doing something to calm them? Is it a way to just kind of center them? Is it helpful? So I'm a big proponent, if it is not hurting them, it is not inhibiting their quality of life, why do we need to look at it? And I feel like one of the big things years ago was even eye contact. Like they need to look you in the eye. Why? So that we've come a long way where that's not even something that's very like goal oriented, and I think stimming is now going down that route of why, and I think there's some pushback. It's not socially appropriate, but who's to say? Who's to say that someone biting their nails, why is that okay? But if someone wants to hand flap, why is that not?
Right.
So I am a proponent where if it is helping them, it's not like no damage is being done. They're not getting upset by it. And I think with what you said about like maybe a disruption to a learning environment, I think for a lot of those cases, it might be education for everyone around them.
Mhm.
It's not always that that child has to change. Sometimes this is helping them, or this is, maybe they're getting a little frustrated. This is their way of kind of getting that energy out of their body, or whatever that could be. So that's my personal approach to it.
Sure. And then to follow that up, let's say the child, would you consider it affecting their well-being if like they're getting older and the other kids are just giving them a really hard time about it, and maybe they do want to do less of it or none of it? Then the
Yeah,
goal I think would be to figure out how it's serving them, like what is it providing, and find an
exactly.
agreeable substitute that's maybe less, I don't know what word to even put there.
Yeah. No, absolutely. And we, similar with behavior, we do that a lot with sensory. So looking for something, we have some kids that just want to touch hair. They just want to touch it the way it feels. Unfortunately, you can't go up to someone and just pet their hair. So we
Right.
kind of look at things. Is it, like a Barbie doll, or is it something that, they can like tinsel or something that they can get that same kind of sensory? So it definitely is looking, we do try to be age appropriate. If there's an adult that is carrying around a rattle because they like the way it sounds, it's definitely going to look a certain way, and be perceived a certain way. Is there something else that we could, use? A maraca, something, something that's a little bit more age appropriate. So yes, we always want to see what is it serving, what is that function, and can we replace it with something that maybe is a little bit more appropriate. So if it is, maybe even just like the squeezing or something like that, that they feel that helps them and secures. So what are ways that we can do it? And we've even seen, the growth of just fidget toys. I think everybody uses fidget
Yes.
toys, and, different things like that have really been helping, I think, people to just have anxiety and just, get a little fidgety. So I think also the acceptance of those, kind of behaviors is also changing, which I love to see in society as well.
Yep, I love that. Okay, awesome. Well, that was super, super helpful. To sum it up, I think it's just there's some common truths here. Like we were clearly
Sure.
speaking specifically about ABA, but I feel like almost everything you shared could be applied to like any of the other
Yes,
therapies or
sure.
fields. So, really useful information, even for someone like myself who did not explore ABA for my kiddo. And thank goodness, because it would have been back in the darker days
Sure.
where it was maybe not so awesome.
Sure.
But I think it's true that, not all providers, clinicians' practices are created equal. So we
Sure.
just want to take this information. If it's something we're looking into, just ask a lot of questions, be very observant,
Yeah.
notice the impact it's having on your kiddo, and you can always switch or not even start with that, person. Um, and as with all things parenting, all we can do, we're all doing the best we can with the
100%.
resources we have and the information that's available to us at any given time. So we were talking before we hit record about like maybe the conversation shouldn't be should we do ABA or should we not? If should we not, if that's what's available and that's what insurance will cover, some parents may have to explore that out of necessity. So then the question becomes, how can we find a compassionate, maybe
Sure.
neuroaffirming provider and avoid the ones who maybe aren't so much.
Sure.
Learn more, do better, whatever,
Yeah.
and don't beat yourself up, if you didn't know any of this
Yeah.
until now. So thank you for dispelling a lot of those
Yeah.
misconceptions, and thank you for
Sure.
your time. Families, you can feel free to reach out to Stacey via email if you have follow-up questions or you want to take advantage of the 15-minute complimentary consultation. And it sounds like you, even if you weren't the right provider, you'd be happy to help families, get
Absolutely.
to the right place or get on the right path, which we always appreciate. We're all helpers and we're just trying to get
Mhm.
families where they need to, right?
Absolutely. Absolutely. And just to plug, BNT does, we have two other phenomenal therapists that do more of a mental health counseling approach. And they focus on ADHD, they focus on anxiety, working with teens and adults. So even just checking out the page, it might not be me, that's fine. But there are, we also have two amazing clinicians that have a little bit of a varied approach that might be worth that 15-minute call too for them.
Yep. And all virtual, just to
Yes.
emphasize that point too.
Yes. Yes.
Awesome. Thank you so much for your time, Stacey.
Sure.
Parents, caregivers, thank you so much for watching. I will be back soon with more experts for your exceptional child and more information. And have a good rest of your night.